When you're dealing with a serious illness, I mean, it throws a lot at everyone, doesn't it?
Yeah, it does. It really
Not
does.
just the person who is going through it, but everyone around them too.
Definitely.
Their families, the healthcare workers. It can be such a tough thing to navigate.
It really can be. The emotional weight is huge, and the stakes are so high for everyone.
And that's why we thought it was important to take a deeper look at the ethical side of things when it comes to palliative care.
Absolutely.
So when we talk about palliative care, the big idea is to make life better, to improve the quality of life for patients and their families when they're facing a life-threatening illness.
Yes.
It's about making them comfortable, supporting them, and trying to create the best possible experience for everyone.
You know, one of the most interesting things about understanding the ethical principles in palliative care is that it's not just some kind of abstract theory.
Right.
For patients and their families, it can really help them make sense of things and give them some sense of control during a time that can feel really chaotic. And for healthcare workers, a deep understanding of these principles can be really empowering, providing a roadmap when they're in challenging and sensitive situations.
Right, because even in those really tough, really emotional times, clear communication and understanding those ethical principles,
It's everything.
yeah, it can really lead to finding solutions that genuinely respect the individual and their values.
For sure.
So where do we even begin unpacking this whole thing about the ethics of palliative care?
Well, I think a good place to start is with the basic ethical principles that guide all of clinical medicine.
Okay.
These are often called the four key principles: autonomy, beneficence, non-maleficence, and justice. And these were really laid out in detail by Beauchamp and Childress.
Those are some big words. Can you break them down for us a little bit?
Of course, but it's really important to remember right from the start that no one principle is automatically more important than another. How they're used always depends on the specifics of the situation.
Okay, good point. So let's start with that first one, autonomy. What does that mean in this context?
At its heart, autonomy is about recognizing that every person has inherent worth and has the right to make their own choices about their health and their life.
So respecting someone's ability to make their own calls.
Exactly. And when we talk about making decisions, two important concepts come up: competency and capacity. They're often used in a similar way, but there is a distinction.
Okay.
Competency usually has a legal meaning. It's a formal decision, often by a court, about whether someone is legally capable of making decisions about their own affairs. Capacity in a medical context is more about a person's actual ability to understand information, to really grasp the consequences of their choices, and to communicate what they want.
That's a helpful distinction. Can you give me an example of that?
Sure. So in a hospital, a doctor would be focused on assessing a patient's capacity to make decisions about their treatment right there and then. Can they understand the information being given to them? Can they weigh the pros and cons? Can they express their decision? A court, on the other hand, might be looking more broadly at someone's competency to manage all their affairs, including finances, property, and healthcare decisions over the long term.
I see. So how does autonomy actually play out in the day-to-day world of palliative care?
It affects pretty much every aspect. For example, it's the foundation of informed consent. That's making sure patients get clear and honest information about their condition, what treatments are possible, what could happen, both good and bad outcomes. Also, they can make informed choices. It's also about truth-telling and disclosure, being honest with patients about their diagnosis, what they can expect, and maintaining their confidentiality. It's about respecting their privacy.
Now, what happens if a patient can't make their own decisions? Like if they're too sick or if they're not able to communicate?
Then a surrogate decision maker comes into play.
A surrogate decision maker.
Okay.
Sometimes they're called a healthcare proxy. So if a patient loses the ability to make decisions for themselves, they may have already named someone they trust to make those decisions for them. This person would act based on what they believe the patient would want or what's in their best interest.
We actually had a listener, Jeannie, who works in pre-hospital care, ask a question about this. She mentioned that in South Africa, living wills aren't legally binding right now, and she asked about the legal weight of a healthcare proxy.
Ah, yes. Jeannie's question is a really important one, and it highlights something specific about the legal situation here in South Africa. While there may not be a specific legal document for healthcare proxies that has the same force as, say, a power of attorney for finances, the wishes of the patient in choosing someone to speak for them still matter a lot. Healthcare teams will generally follow those wishes.
That makes sense.
But here's the key. It's absolutely crucial to have that nomination written down in the patient's medical records. ideally with witnesses and signatures.
And like Jeannie also mentioned, open communication between the chosen proxy and the rest of the family is so important. You want to try to avoid disagreements later on, even if the proxy ultimately has the final say.
So it sounds like even without a super strict legal document, clear documentation and communication are really what matters.
Exactly. It's about making sure everyone's on the same page as much as possible.
You talked about informed consent earlier. What does that really involve?
Informed consent is not just about signing a form. It's a whole process, a conversation between the healthcare provider and the patient that should be happening all the time.
Okay.
It needs to be participatory. That means the patient isn't just passively listening, they're actively involved in the conversation.
Right.
They have to be given enough information, explained in a way they can understand, about what's going on with their health, what the proposed treatment is, what the risks and benefits are, and what other options they have.
Including the option of not having the treatment at all.
Exactly. And they need to understand what could happen with each option and be able to think through it all. The HPCSA guidelines for good practice and the National Patients' Rights Charter are both really important frameworks for this whole process.
Right.
And it's really important to keep thorough records of every conversation, every decision.
Absolutely.
Yeah.
And whose responsibility is it to make sure they've got that consent?
It's usually the clinician who's going to be doing the treatment or investigation.
Right.
While they can have other people on the team help with explaining things, the ultimate responsibility to ensure that the patient understands everything and is freely consenting falls on that clinician.
Okay.
And voluntarily is the key word there.
Got it.
Patients should never feel pressured or coerced into a decision. It has to be their choice, freely made.
Got it. Now, you mentioned advanced care planning and advanced directives too, like living wills. How do those fit into the idea of autonomy?
These are really valuable tools, especially when we're talking about palliative care. Advanced care planning is basically a conversation where the patient, their family, and their healthcare team talk about what they want to happen with their care in the future, just in case they become unable to speak for themselves.
So, planning ahead.
Exactly. An advanced directive, or living will, is where you put all those decisions in writing, like saying, if I can't speak for myself later on, here's what's really important to me when it comes to my medical care. The HPCA Advanced Healthcare Plan document is a really good resource for this.
Okay.
It helps you think about things like what you value most in your life, what abilities are essential for you to feel like you have a good quality of life, and what worries you about dying.
Right.
It also has you think about who you want to speak for you if you can't speak for yourself anymore. And while, as Jeannie pointed out, these documents might not always be legally binding here in South Africa, they give the healthcare team and the family vital guidance about what the patient wants.
So even though it's not like a legal contract, it's still incredibly helpful.
Yes, exactly. It helps to avoid confusion and guesswork later on when decisions might be even harder to make.
Once these plans are written down, are they set in stone or can they change?
Things change, people change. That's why it's so important to revisit these plans over time.
Okay.
We heard about this in the ethics.mp3 source. People's wishes can evolve, even if they've written something down. There was even an example of a patient who had said they didn't want any aggressive interventions, but then when they were closer to death, they wanted a blood transfusion so they could see their grandchild graduate.
Sure.
It's a good reminder to keep the conversation going and to respect what the patient wants in the moment.
That's a really powerful example. And what about the patient's right to refuse treatment? That must be a big part of autonomy.
It's a cornerstone. If a patient understands what's happening and what the consequences might be, they have every right to say no to any medical treatment, even if it could keep them alive. Ideally, this should be talked about in depth, documented, and witnessed if possible.
That's what they were talking about in the ethics.mp3 discussion, right?
Yeah, exactly. It can be tough for healthcare professionals to hear that a patient is refusing something they think could help. But respecting autonomy means honoring those informed decisions.
There's another concept you mentioned earlier, futility. Could you explain what that means in terms of treatment decisions?
Futility comes up when healthcare providers believe that further treatment wouldn't be medically appropriate or it simply wouldn't benefit the patient in any meaningful way.
I see.
And the HPCSA guidelines, as mentioned in ethics.mp3, say that healthcare providers aren't obligated to provide treatment that's considered futile.
Even if the patient or family requests it.
That's right. Respecting the patient's wishes is super important, but there's also a responsibility to not do things that won't help and might even cause more suffering. Deciding if something is futile can be complex, though. It should ideally involve the whole healthcare team, and there needs to be open and honest communication with the patient and their family.
That makes sense. So we've talked about autonomy in a lot of detail. What about those other three principles?
Yes. Beneficence, non-maleficence, and justice.
Okay.
Well, beneficence is about acting in the best interests of the patient. It's about doing good and promoting their well-being. Non-maleficence is about avoiding harm. First, do no harm, as the old saying goes.
Right.
Those two principles often go hand in hand when doctors are making decisions about treatments.
And justice. Does that have more to do with the bigger picture?
Yeah, justice is a bit broader. It's about fairness, particularly when it comes to resources.
So, like, if a hospital only has so many beds in the ICU, who gets one?
Exactly.
It's a tough one.
It is, and there are lots of different ways to think about what's fair. Should everyone get an equal share? Should it be based on who needs it most, or who's worked the hardest, or who's contributed the most to society? These are the kind of questions justice raises, and they often play out in policy decisions.
So it sounds like these four principles, while they're all important, could sometimes be at odds with each other.
That definitely happens.
Like, what if a patient refuses a treatment that the doctors think is in their best interest?
Yeah, that's a perfect example. You've got beneficence pulling in one direction, wanting to do good by giving the treatment and autonomy pulling in the other, respecting the patient's right to say no. And as the principles of clinical ethics and their application in practice 2021.pdf points out, these kinds of conflicts aren't uncommon at all. Figuring out how to navigate them is a core part of ethical decision-making in palliative care.
So when you're faced with a situation where there's no easy answer, or you have to choose between options that aren't ideal, what do?
That's what we call a moral or ethical dilemma. And there's a 5-step approach that can help you figure out what to do.
A 5-step approach. Okay, I'm listening.
It's outlined in Ethics Slides, IPC.pdf, and it was also mentioned in ethics.mp4.
Got it.
So the first step is to figure out exactly what the dilemma is.
What's the conflict? What values are clashing?
Right. Once you've got that clear in your mind, the next step is to gather all the information you need. And by information, I mean everything you can find out about the patient, their life story, their medical history, what they've said they want for their care, their family's resources, the family's wishes, the diagnosis, the prognosis.
Wow, that's a lot to take in.
It is, but the more complete a picture you have, the better equipped you'll be to make a good decision.
Okay, makes sense.
And Module 2 Ethics Short Course HPCA Odell edits.pdf really emphasizes that.
Great. So you've got the dilemma figured out. You've gathered all the info. What happens next?
The third step is to analyze all that information. You've got to look at the context, who all the players are, and how the different ethical principles apply.
Right.
Then, in step 4, you come up with some possible solutions, make recommendations, and choose a course of action.
So weighing everything you've learned.
Exactly. And then the final step, step 5, is where you implement policy. This step is often overlooked, but it's super important.
Okay.
We heard in ethics.mp3 about the paraquat poisoning situation and how having clear policies in place for situations that come up often can really help.
Right.
It can help reduce the moral distress that healthcare workers often feel when they're dealing with these tough choices, and it makes decision-making more efficient.
Policies provide a framework to help make those difficult decisions in a more consistent way.
Exactly.
Now let's talk about some of the specific ethical issues that come up a lot in palliative care. Truth-telling feels like a big one, especially for patients and families.
It is. Honest and sensitive communication is crucial in palliative care. And it's not just about giving information, it's about offering hope. It's about reassuring patients that they're not going to be abandoned.
That they're still going to be cared for.
Yes, and Module 2 Ethics Short Course HPCA Odell edits.pdf really stresses that. For patients and families, honesty delivered with empathy can help build trust and open the door to meaningful conversations about what matters most to them.
Right.
There was a really good point made in the ethics.mp3 discussion, too, about how it's important to gauge how much information a patient wants at any given time.
Some people want to know everything, and some people don't.
Exactly. And while there's been a trend in the U.S., as mentioned in the Principles of Clinical Ethics and their application in practice 2021.pdf, to move towards being completely open with patients about everything, it's essential to be sensitive to cultural differences and individual preferences.
So it's a balancing act for healthcare providers.
It is. It's about being truthful and respecting what the patient feels ready to hear.
What about withholding or withdrawing treatment? That must be really hard for everyone involved.
It is. But ethically, it's considered acceptable to withhold or withdraw treatment when the treatment is no longer beneficial, when it's what we call futile, or when it aligns with the patient's informed wishes.
Right.
And this decision should always involve open discussions with the patient, if they're able, with the family, and with the whole care team.
Okay.
And the WHPCA position paper on euthanasia from 2016 really highlights that.
So for patients and families, knowing that the focus will shift to quality of life when treatments aren't helping anymore can be a comfort.
Absolutely. It's about understanding the difference between interventions that truly improve quality of life and prolong life in a meaningful way, and interventions that just prolong the dying process without any real benefit.
And palliative sedation is that different ethically?
Yeah, palliative sedation is about using medications to relieve suffering that's become unbearable. The goal, as the WHPCA paper explains, is to reduce distress, to help the patient relax, ideally to the point where they can still interact with their family, but without making them completely unconscious. Deep sedation might be used for a little while if someone is in extreme distress, but the intention is always to manage symptoms, not to speed up death.
So it's about comfort, not hastening the end.
Exactly. For patients and families, that distinction can be really important. It helps to know that the goal is always comfort.
Okay. Now let's talk about something that's always difficult.
Yeah.
Euthanasia and physician-assisted suicide.
They are very sensitive topics, and we need to define them clearly.
Yes, absolutely.
And both the WHPCA position paper and the paper by Norval Gwyther do a good job of that. So euthanasia is when a doctor gives a patient medication with the intention of causing death, and this is done at the patient's request, when they're mentally capable and making the choice freely. Physician-assisted suicide is a little different. It's when a doctor provides the means for a patient to end their own life, usually a prescription for a lethal dose of medication, but the patient is the one who takes it.
What's the position of palliative care in South Africa on these practices?
The WHPCA and palliative care providers in South Africa don't support euthanasia or physician-assisted suicide. They are both illegal in South Africa.
Right.
And we talked about this a bit in the ethics.mp3 source, and it's also spelled out in the WHPCA position paper.
Okay.
The fundamental principle of palliative care is not to hasten death, but also not to unnecessarily prolong suffering. So the focus is always on making sure people are comfortable and have the best possible quality of life within the natural course of their illness.
The Gwyther reading brought up some arguments against euthanasia and assisted suicide as well, didn't it?
Yes. It mentioned the concern about what's called a slippery slope, that allowing these practices could lead to situations where people are pressured into ending their lives, even if they don't truly want to.
That's a worrying thought.
It is. And it also raised the possibility of involuntary euthanasia, people being euthanized without their consent.
Oh, that's scary.
Yeah, it's a valid concern. And there's also the worry that people left behind the family and friends might have a harder time grieving if they feel like they were somehow involved in the death.
That makes sense.
And a really important point the reading made was that once good palliative care is in place, requests for euthanasia often go way down.
Oh, that's really interesting.
So it really emphasizes the importance of making sure people have access to the best possible palliative care.
Definitely. And there was also mention of something called the doctrine of double effect. What is that?
It's a bit of a tricky concept, but basically it's about situations where you do something that has a good outcome as the main goal, like relieving pain, even if you know there's a chance it could also have a bad side effect, like a slightly shorter lifespan. It's the intention that matters.
I see.
It's covered in both the Gwyther reading and the paper on pediatric palliative care ethics.
Right. And thinking about palliative care for children, I imagine there are specific ethical considerations there too.
Absolutely. The pediatric palliative care ethics paper talks about how children have specific rights.
Okay.
Like their best interests always have to come first. Their families need to be recognized as full partners in their care, and they should be involved in decisions as much as they can, given their age and understanding.
It sounds as open and honest communication with children is really important too.
It is, but it has to be done in a way that's appropriate for the child's age and level of understanding.
Right.
And there's also the concept of allow natural death, or AND, which is often preferred over do not resuscitate, or DNR in pediatric palliative care.
Oh, that's interesting. I haven't heard that one before.
Yeah. And SENDI is about focusing on letting the dying process happen naturally while making sure the child is as comfortable as possible and has the support they need.
Okay. That makes sense. So it recognizes the unique vulnerabilities of children.
Exactly.
And now we need to talk about something really challenging. Justice. and how resources are allocated in palliative care, especially in a country like South Africa, where resources are limited.
Yeah, this is a big one. It affects whether patients can even get the care they need and how well healthcare workers can provide it.
And this was highlighted in the ethics.mp3 discussion, wasn't it?
Yes, Floyd Fent talked about the shortage of morphine and how the lack of resources, despite what the government has said they'll provide, creates real ethical dilemmas.
Right.
When healthcare providers can't even get basic pain medications for their patients, it causes a lot of moral distress for them and unnecessary suffering for the patients.
It's a terrible situation.
It is. And PALPRA, the Palliative Care Association of South Africa, is doing important work to try to address these problems at a systemic level and make sure everyone has access to the palliative care they need.
It sounds like they've got a tough job.
They do. And the COVID-19 pandemic brought these resource allocation issues into even sharper focus.
Yeah.
It became clear how important it is to make sure resources are allocated fairly, without discrimination, especially during a crisis.
And I think that point is also made in the Principles of Clinical Ethics and their Application in Practice 2021 paper.
Yes. Case 6 in that paper is a good example of that.
Okay. And given all these complex ethical considerations, teamwork and communication seem more important than ever.
Absolutely. Making ethical decisions in isolation is almost never the best approach. It's much better to work together with colleagues, with families, and to be open and honest in all your communication.
Like in the ethics.mp3 discussion about Mr. B's case.
Yes. That case really highlighted how important it is to involve the family and to work together to make decisions. For patients and families, feeling heard and being included in the process is really important.
Absolutely. And the approach to care overall and the professionalism of healthcare providers must have a huge impact on the ethical side of palliative care, too.
They do. The Principles of Clinical Ethics and their Application in Practice 2021.pdf talks about how caring should be at the center of patient care.
Okay.
This means that ethical considerations are woven into everything, along with professionalism and clinical and technical skills. Virtues like compassion, good judgment, trustworthiness, integrity, and conscientiousness, all of those are crucial for providing ethical and high-quality palliative care.
And those were all things that were discussed in both the Principles document and ethics.mp3.
Right. For healthcare providers, embodying those virtues helps to build trust with patients and their families.
So we've talked a lot about the ethical principles of palliative care. Maybe we can go through a quick example to help put it all together.
Okay.
In the ethics slides IPC.pdf, they mentioned a case about a man named Mr. B.
Oh, yes, Mr. B. I remember that case.
He was 59 years old, had esophageal cancer, was bedridden, and had a peg for feeding.
Right.
His wife believed that he wouldn't want to live like that and wanted to stop the feeding, but his son and daughter wanted to continue it because they were worried he'd starve.
And there was no advanced care plan in place.
No. So how could we use that 5-step approach to make a decision in a situation like this?
Well, this is a classic example of a tough ethical dilemma that families and healthcare teams face all the time. The first thing we do is try to define the dilemma.
Okay.
In this case, it's about how to balance respecting the wife's belief about what Mr. B would want with the children's concerns about his nutrition, especially without clear instructions from Mr. B himself.
Right. It's that conflict between autonomy and beneficence.
Exactly. And then the second step is gathering information.
So what kind of information would be important here?
Well, were there any conversations beforehand where Mr. B talked about what he wanted for his end-of-life care? What were his values?
Right.
What did he consider a good quality of life? What's his current medical condition and prognosis? And what are the reasons behind the wife's and the children's viewpoints? It's really important to understand where everyone's coming from.
It's about seeing the whole picture.
It is. And once you have all that information, step 3 is analyzing it.
Okay.
We need to consider the principle of autonomy.
Even though Mr. B can't speak for himself anymore.
Exactly. We'd try our best to figure out what he would have wanted.
And there's also beneficence and non-maleficence to consider.
Right. Which choice would truly be in his best interests?
Right.
And which choice would avoid causing him unnecessary suffering?
Right.
And of course, we have to acknowledge the different views within the family.
So what are some possible solutions?
Well, one thing we could do is bring everyone together for a family meeting with the healthcare team.
A chance to talk it through.
Exactly. It would be an opportunity to hear everyone out and try to find some common ground.
Right.
The healthcare team could also see if there's any way to get more information about what Mr. B might have wanted, maybe by talking to close friends or other relatives.
Okay.
If it's still unclear what Mr. B's wishes were and the family can't agree, The healthcare team might have to make what's called a best interest decision.
So they'd have to weigh all the information and the ethical principles to make the best decision for Mr. B.
Exactly.
And even though this particular case might not be covered by any specific policy, it highlights the importance of healthcare teams having clear procedures for handling these kinds of family disagreements.
Absolutely.
And good communication and documentation are essential throughout the whole process.
They are. It's crucial to keep detailed records of all the discussions, what information was considered, and why decisions were made.
Okay.
This protects the patient, supports the family, and provides a record for the healthcare team.
So this deep dive has been really helpful. It's shown how central ethical considerations are in providing compassionate and effective care for people facing life-threatening illnesses and for their families.
Absolutely.
Hopefully, patients and families listening will feel reassured, and healthcare professionals will feel more knowledgeable and confident in how they approach these situations.
And what I think is really important is that understanding these principles empowers patients to be more involved in their own care.
Yeah.
And it gives healthcare professionals a strong foundation to work from when they're dealing with these complex and sensitive issues.
We've covered a lot today, but we encourage all our listeners to think about what we've talked about and how these principles might play a role in their own lives.
Yes.
Whether they're facing a health crisis themselves, supporting someone they love, or working in healthcare.
And as medicine keeps advancing and we have more and more options, there's a really important question we all need to think about. How do we make sure that our ethical compass always puts the individual's values and quality of life first?
That's a great question.
It's a conversation that's constantly evolving,
Yeah.
and everyone's input is valuable.
Absolutely.